Hi, everyone, and welcome to SCN8A Unraveled. I'm Sarah Kay with the International SCN8A Alliance, and today I'll be viewing Josh Hack, a researcher at the University of Arizona. Josh, would you like to introduce yourself?
Yeah, hi everyone. I'm Joshua Hack. I've been involved with the Hammer Lab at the University of Arizona for the last 3.5 years, working primarily with the data that the community has provided us through the SCN8A patient registry and doing a lot of machine learning work and modeling with that.
Great. Well, we are so happy to have you here today to talk about your research on personalized medicine and machine learning. So, to start us off, can you tell us a little bit more about machine learning?
Yeah, and the background information here is a little bit technical, but for the most part, I will do my best to make it relatable to everyone. And so to answer the question of what is a machine learning model, it's really a combination of computational work and statistics that takes a lot of data and large data sets from researchers and is able to organize it into different categories. And so some of these models are a lot simpler than others. So for example, we have linear regression, which takes into account 2 or 3 features to be able to use those inputs and identify correlations between your input and your output, or features and variables. So for example, in the case of SCN8A, we can model the relationship between age at seizure onset and development using linear regression. So this is one of the simpler models, and there's plenty that are more complicated, but one that we use frequently is what's called a random forest model. And a random forest is a collection of decision trees, which typically follow a basic decision-making logic. So for example, if you're trying to decide every day whether you want to bring a jacket with you, and you're looking at the weather and you know, based off of a variety of experiences, that on a normal day when there's no wind, it's not overcast, you can typically go down to 65 to 70 without a jacket. But you also know that if there is wind or if it's overcast, that temperature might decrease or increase a little bit, and as to when you want to bring that jacket. And so you have all of these different decision-making processes going on in your head to evaluate whether or not, based off of, okay, today is going to be 68 degrees out, overcast with a little bit of wind. Based off of all of that prior experience, you can use the collection of that to come out with the final decision that you want to bring a jacket with you. And so random forests are typically designed off of anywhere between 500 and 1,000 different decision trees for that final output. That can get as complicated as up to 10,000 different trees, depending on what data you're analyzing and how nuanced it is. And so random forests, on the opposite end of the spectrum from linear regression, is able to take into account many variables and able to coalesce that into one final decision. And so there's a lot of benefits to using these models for studying large data sets. They can find patterns in the data that we as researchers and clinicians might be missing just because of the size of the data set that we're looking at. And it can process everything a whole lot faster than we can. So any new patterns that they identify can be turned into new research questions to explore more in depth. And that's done in a variety of ways. And the main way that we go about testing these models is by splitting it into what's called a training set and a testing set. So if you think back to your days at school and preparing for an exam, you would be studying by looking at study guides, by looking at previous exam materials, so that you can get a general idea of what's going to be on that exam and get an idea of the format of those questions, how your responses will be worded, or if it's a multiple choice question, which of those options is going to be the correct one. And all of that is done in preparation for the final exam, but none of those questions, or at least very few of those questions, are going to be on that actual exam in the exact same way that it's been on previous exams or in the study guide. And so all of that training then is tested on that final exam, and you can get a general idea of how well you know the material and how well you're able to respond to each of those inputs. So we do a very similar process with machine learning, splitting that data set into its training set and test set, and keep it completely apart from the test set so that it's not seeing that data. And this is largely done to prevent what we call overfitting, which is just predicting with an accuracy higher than what it actually performs at, so we can limit the amount of bias going into the final performance of that model. So all of that is great for identifying new patterns, but ultimately the biggest drawback of machine learning is what we call a black box within the learner. And this is especially present in more complex models, such as random forest or neural networks, which are the base of like AI packaging and AI models. And the black box essentially just obscures everything and the logic that's going on within that model. So we as researchers can evaluate the performance of the model by testing its predictive accuracy. We can identify the features that are contributing the most to that predictive accuracy and how they're contributing. But ultimately, we don't know why each individual data point is predicted the way it is. And so we as researchers are tasked with making and translating those models into something that is actually usable and understandable by clinicians and anyone who is looking to benefit from the use of these models. And unfortunately, a lot of the time, this comes across as us just hand waving and saying, you have to just trust the data or trust the process, which it's technically valid, but it's never actually satisfying on the receiving end of it. And we as researchers really also aren't satisfied with that answer, but there's no way to actually access that deeper logic within the neural network.
You're right. Does sound very complicated, but it sounds like you put something in, you get something out, but at the end of the day, you just really have no way to track kind of how these models get to the decisions that are made at the end.
Correct.
So that's good to know. So then how have you been using this in regard to SCN8A?
Yeah, and that really is the big question. So why do we even care about all of this, and how is it all applicable? And so the work that we're doing is really complex and not fully complete quite yet, but we've managed to make it through a significant portion of it towards the goal of applying computational and machine learning methods to provide personalized medicine for patients based off of early life features. And this is what we're calling a machine learning pipeline. That is 3 different machine learning models looking at the genetic or the functional effect of a patient's variant, and then identifying whether they're going to be mild, moderate, or severe, and ultimately looking towards being able to provide a list of the top 5 treatment options for that patient based off of all of these features. And the goal is to get that information as early in the disease progression as possible so that we can limit the amount of negative effects from prolonged periods with ineffective treatment. So that brings us to the inputs and what data we're actually using with these machine learning models. And as I've said, all of this is data that is easily collected early in a patient's progression throughout the disease. So we're looking specifically at the age of seizure onset and their initial seizure types. And then if seizure freedom or prolonged seizure freedom, so it's a period of at least 6 months where seizures were not experienced. And then also looking at developmental data. So that's the developmental quotient, which is typically on a scale of 0 to 100. And that's just marking off what age they were able to acquire developmental milestones. And then if they have a developmental delay or not. And genetic information. So the type of variant that they have, where that variant is throughout the SCN8A gene, and hopefully get a better idea of how variants will correlate with disease outcomes. So all of these inputs are being incorporated into each of our models to hopefully get a better idea of patterns that we may have been missing in previous work, and be able to predict a patient's outcome based off of these features. So the first phase of the model is what I'm calling the diagnostic phase. And it takes these inputs, so seizure type, seizure onset, development, and their genotype, and feeds all of that into a random forest classifier. So that is 500 individual decision trees coming to a final consensus on whether a patient is likely to have a variant that is gain of function or loss of function. All of the data that we used in this study was provided by either the International SCN8A Patient Registry or found in literature. And so interacting with studies and incorporating your data and your patient's life into, or your child's life into the registry and literature really expands our ability to understand the disease. And it's extremely important for developing better ideas of how to treat this disease. Ultimately, this model performed extremely well with 94% accuracy using 5 simple features from early disease progression, which means that 94% of the time it was able to accurately predict a patient as having a loss of function or a gain of function variant, which is incredible performance for any machine learning model. The second model is the prognostic phase, and this is where everything gets a little bit more complicated because we are interested only in gain of function variants in the population that has those. And we have 3 different potential outcomes. In the case of the loss of function population, the reason we exclude them is because for the most part, it splits itself into 2 different groups, those that experience seizures and those that don't. Within the gain of function, we have a spectrum of severity outcomes, and those can be grouped in typically 3 different ways. And so because of how complicated this was and the issues with differentiating patients into these groups, we used 2 different approaches, one of them based on clinical experience, using a doctor's logic. And so that's a bit simpler to understand why an individual might fall into a certain group. The other way that we went about classifying patients was using a statistical approach, using machine learning to identify how patients cluster in a larger data set so that we can limit the amount of bias that is being brought into the methods. And so these 2 models were able to perform with 90 to 95% accuracy using the same early life features. And by using both models rather than just limiting to one, these both provide an output for a future use so that we can have both the previous clinical knowledge as well as the limited bias through the statistical approach in our end goal of being able to determine the optimal treatment for an individual.
Wow, that's amazing. So then putting all of this together, do you have some examples of what this whole process would look like?
Yeah, so here, for the sake of keeping it simple, we'll provide 2 general cases. Patient 1 will be tracked in blue across our pipeline, and patient 1 will have experienced generalized tonic-clonic seizures and absent seizures with an onset of around 10 months, moderate intellectual disability, and a missense variant. Patient 2 will have a similar profile with generalized tonic-clonic seizures and atonic seizures, but the seizure onset will be at 5 months, and severe intellectual delay, also with a missense variant. So we feed all of this data into our models as an input, and tracking patient 1 in blue, they're more than likely going to be loss of function, with a later seizure onset and absent seizures being included in their initial seizure type. From here, it's very easy to determine whether they are in the seizure experiencing subpopulation or not. They do experience seizures, and so we can treat them with an anti-seizure medication that is not a sodium channel blocker, as that might exacerbate the symptoms. The second patient is more than likely going to be gain of function, which would then feed into our prognostic model and more than likely predict them as being a moderate case. And from there, we can identify the top 5 likely treatments for that individual based off of those features, based off of the outputs from the diagnostic phase and the prognostic phase. and generate a customized therapy for them based off of all of that information and taking into account their entire profile. So that's a general idea of how the machine learning pipeline will work in its fully realized form.
Yeah, that is so interesting. Thanks for bringing these examples. So it sounds like this could give families a much better understanding of how their child may progress, which is obviously really important. So I guess where do you go from here?
Yeah, and our future work is going to be verging much closer to an artificial intelligence system where it's able to learn from the new data that it's being given, and is able to take into account a whole lot more data and make everything a bit more flexible. So all of these machine learning models are much more rigid in that it's only able to categorize into the different groups or outputs that you're feeding into it. And so while it's able to access and answer targeted questions, it's not able to take into account as much new information as, say, artificial intelligence would. And so with our future work, as I said, we're working towards more of an artificial intelligence model that's able to take into account treatment information. And all of that is the goal of providing clinicians and caretakers with a list of the top 5 treatment options, whether that is sodium channel blockers, a combination of these medications, or just using one, different other anti-seizure medications, and then maybe an alternative therapy such as ketogenic diet or vagus nerve stimulation. And being able to inform those people using that model to get a better idea of what medications and what treatment options are going to be best for that patient. And then finally, a large part of all of this work is making it accessible to everyone. And that will be developing a web-based tool so that individuals can put in a patient's information and it'll feed all of that through this entire pipeline so that you get an output and response of, okay, your patient is more than likely loss or gain of function. Your patient is more than likely falling into one of these categories. And because of all of that, and because of the information that you've fed it, here's the top 5 treatment options that we would recommend based off of the large data set that we're collecting, as well as medications to avoid or therapies to avoid. And so that will be able to empower caretakers to help inform and guide their treatment, as well as help clinicians who maybe haven't had any experience with an individual with SCN8A to have a better idea of how they should go about treating this individual as early as possible in a patient's progression through their disease. So all of this is really great work and has been absolutely massive in regards to a breakthrough and identifying new patterns and understandings of the disease. But ultimately, we still have a lot of areas that need illumination. And so one of these questions is, how do we identify and treat patients that have a variant that has mixed loss and gain of function behavior? Another one is the gain of function population actually 3 distinct groups, or is it more of a spectrum? And if it is a spectrum, how do we quantify and predict where a patient falls along that spectrum? Are there patterns of association in effective treatments within these groups? And then what other features of the disease are we missing in our modeling? So can we actually incorporate EEG data into our modeling? Can we incorporate comorbidities into our modeling and use that to inform likely outcome of a patient? Or can we predict the comorbidities that a patient will experience over the course of their life based off of these early life features? So all of this requires a lot more work and a lot more data. And while machine learning can provide insight into each of these questions, ultimately, it will be a bit before we're able to actually definitively answer any of these. And that is mostly due to having come up with the right methods and also the correct data and a significant amount of data to be able to look into all of that. So that finally brings me to how the community can contribute to our research and bring deeper understanding of all of these aspects to SCN8A. And that's by continuing to support the International SCN8A Patient Registry, providing your experience and data for us to continue to use. And it's especially important to fill out annual updates so that we can get longitudinal data as a patient ages and progresses through their life, so that we can study how this disease will progress and also get a better idea of effective treatments. So what we have done so far would be next to impossible without data already provided by you in the SCN8A community. And we hope to better be able to serve you in the future with more analyses and better understanding of SCN8A so that we can improve the quality of life of every patient with SCN8A. Thank you all so much for being active contributors to our research, and thank you in advance for continuing to provide the data we at the Hammer Lab need to increase our capacity to give back to you.
Thank you, Josh. Thanks so much for your time and for all of this hard work you've been doing for our community. And we'll look forward to any updates. So to the rest of you, thank you for joining us for SCN8A Unraveled, where we unravel the science of SCN8A.